Call the March 15th PEB board meeting to order. Welcome everyone, and we will start with roll call. Again, I'm Kimberly Hendricks, your chair for just a little bit longer. Greg Klauser.
Here.
Good morning. Andrea Foltz.
Present.
Good morning. Saban Martin.
Here. Morning.
Dawn Motner.
I'm here. Good morning.
Good morning. Kate Nass.
I'm present.
Good morning. Sean Parkman.
Here.
And Jeremy Vandehey. Not yet, looks like. Okay. All right, well, we'll go ahead and get started. Again, welcome to our meeting. And our first agenda item is the approval of the February 15th meeting minutes. Were there any changes, a motion? What do we have?
This is Siobhan Martin.
Hello, Jeremy. I see you. Gotcha.
Morning.
I was about to make a motion that we approve the February 15th, 2022 minutes as written.
Thank you. So we have a motion by Saban.
It's Jeremy. I'll second.
Second by Jeremy. Do we have any questions, corrections, or comments? Okay, I will go ahead and do roll call again. Greg, are you in approval of the minutes as written?
Approve.
Andrea?
Approve.
Saban made the first. Dawn?
Approve.
Thank you. Kate?
Approve.
Thank you. Sean?
Approve.
Thank you. And Jeremy made the second. Looks like the minutes from February 15th are approved as written. All right, next up. So in accordance with Section 4 of the PEBB bylaws, the election of officers occurs no later than March of the even years. I, Kimberly Hendricks, as chair, and Sean Parkman as vice chair, have served in the chair and vice chair's positions for the limit of 4 years. Feels like 4 years. Therefore, the board must elect a new chair for the labor members and a new vice chair for the management members. Action is requested. With that, I will entertain a motion for a new chair of the PEB board.
This is Andrea, and I'm motion to nominate Siobhan for chair.
This is Greg. I'll second that.
And this is Siobhan. I'll accept the nomination.
You all are so well trained. Do we have any other motions for chair? Or nomination, sorry. Okay, well, we're going to do a vote then for Siobhan Martin as our chair for the next 2 years. It's so good for you. So first up, let's see, sorry. So we've got Greg, and I know you made us, yeah, okay.
That's fine.
And Andrea made the first. Saban accepted. Dawn?
By all means.
Thank you. Kate Nass?
Super excited, yes.
Thank you. Sean?
Approve.
I don't hear any corks popping yet. And Jeremy made the, no, Jeremy.
I didn't make the second, but also a super excited yes.
Thank you. Well, it looks unanimous. Saban Martin, you are our new chair of the PEB board for the next 2 years. We're very excited, and you bring such, we're so lucky to have you in any fashion, and this will be great to have you as chair. All right, so now I need an action is requested for a vice chair from the management members. And so I will, and with that, I will entertain a motion for a new vice chair.
Kimberly, this is Kate. I'd like to nominate Jeremy Vandahay.
Okay. Do we have a second? They have their mic off. There we go.
Do you want a management second on that, Kimberly? Because I'm happy to second it.
Yeah, I was gonna say it's,
I'll have to.
It doesn't need to be management.
Then I will enthusiastically second it.
Thank you.
Thank you.
This is Jeremy. I'll accept it as well.
Thank you, Jeremy. Okay, any other nominations for vice chair? Okay, once again, here we go. Thank you, Jeremy. Greg Klauser,
yes.
Andrea Foltz,
Yes.
Saban Martin,
Yes.
Dawn Motner,
Super excited. Yes.
Kate Nass,
Same, yes.
Sean Parkman,
Yes.
and of course, Jeremy accepted. Jeremy, yes. Well, it looks like, congratulations, Jeremy. It looks like you are our vice chair for the next 2 years for the PEB board. Welcome, both of you. Very, very happy to pass the virtual gavel to Saban. And I promise I have not already been in bubbles. I am just very happy for both of you. And this is a great board to be part of. So congratulations, and the meeting is all yours.
All right. Well, I really appreciate that, Kimberly. And I just want to say both to you, Kimberly, and to you, Sean, the direction that you've led us in the last 4 years has really been incredible. And I was reflecting on the fact that we didn't have a strategic vision when I first came on the board. And we've had one for around 4 years now. We had a retreat 4 years ago that both of you helped lead on. We've had successive retreats. We've expanded to really focus in on health equity. And I really appreciate that, Jeremy, you're going to be the vice chair with me, and we'll bring all of your healthcare expertise to those leadership meetings. And just all that value. Sean and Kimberly, again, thank you for leading for the last 4 years. It's been great, and I'm excited to continue in your leadership and continue that vision. And Jeremy, go ahead.
Yeah, I just wanted to echo your kind of words, Siobhan. I think Kimberly and Sean, you guys have done just an incredible job the last few years. We've been so lucky to have you in the leadership positions, and through a retreat, through a pandemic, have just been excellent leaders. So thank you so much for your service, and I'm sure you're excited to have a bit of a break. But thank you so much for all the work and energy you put into it.
All right. So one of the first things I wanted us to consider, I have noticed that OHA has come up with a new healthy meetings policy. And one of the things they've been doing is starting meetings 5 minutes after the hour. And I think a lot of us have back-to-back meetings, thanks to the pandemic, allowing us to go meeting to meeting. And I wanted to know if you all were interested in starting our meetings at 9:35 rather than 9:30 on the dot. And if so, I would entertain a motion for us to do so.
This is Kate, and I very much entertain that motion. I would move to start at 9:35.
This is
This
Sean.
is Dawn. Okay, Sean, you got it.
All right, so I guess I need to do a roll call now. And Kimberly, you get to vote. So
I
why
know,
don't you
I'm so
vote
excited.
first?
I already unmuted. Oh, yes, I'm for
Great.
it. Thank you.
Okay. Greg,
Yes.
Andrea,
Yes.
and Dawn, you were about to second, but you didn't second, so I'll call on you.
Yes, please.
Okay. And Kate, you moved it, so you're yes. And Sean, you seconded it. Jeremy?
Yes.
All right, great. The motion passes unanimously. So our meeting in April will start at 9:35 and our successive meetings will start at 9:35. And the other thing I want you all to think about, and we can discuss it and vote on it in April, Ollie reminded that the state reopens on May 1st, and that means we can consider whether we want to start having hybrid meetings starting in May. And I think that's a discussion that we should have in April. So we could do that at the top of the agenda if you all want to think about that and think about whether we want to offer a hybrid option for folks. All right, so I think we can move to the next agenda item. And I also will just ask, since I'm new to this role, if there's anything I'm missing. And I also want to extend my appreciation to staff as well, because I know you're so instrumental to making this board run smoothly. So please help me as I am in this new role. And I believe we're moving on to the director's report. So I'm handing it off to you, Ollie. Is that right?
That's right. Thank you so much, Siobhan. And we're very excited to have you and Jeremy as the new leadership team. And Kimberly almost sounds giddy today. So I just wanted to take this opportunity to thank Sean and Kimberly for their service on the PEBB board leadership team, which has spanned over 4 years' time with both serving as chair and vice chair. And in that 4 years, they've really made quite a team and managed the board through some challenging times, like we talked about, once in a lifetime pandemic, legislative payment caps, surcharges and incentives, and even breaking ground on health equity. Through it all, they were just positive people to be around, completely giving of their time and attention. And even on weekends, things would come up and they would be right there. And to them, it always seemed to be about the members and making sure families had what they needed and were covered really from head to toe. Speaking for staff, it's just been a real pleasure, and we're just really thankful to have you both still very active on the board and on the innovation work group and the health equity work group and a myriad of other subcommittees that you represent the board on. So thank you so much, Sean and Kimberly. It's really been our pleasure.
Thank you.
So with that, I just wanted to update you quickly on a couple items. We did kick off the PEBB Booster Incentive Program yesterday that provides a $100 incentive payment to employees who personally attest that they have or will get a booster shot. The attestation must occur by the end of April, so they will have 6 weeks to get that done. And we sent out a bunch of communications yesterday, and we have stakeholder help as well, sending out communications, and we'll get the word out to as many people as possible, get as many people to get that done as we can. On the first day, we already had 5,900 attestations, so we're off to a really good start and hope that momentum continues. And then secondly, as Siobhan mentioned, state offices are opening May 1st. That's always subject to change, but we're moving forward with the transition plan for May 1st, and most of it's going around staff planning, and but it also includes board meetings. As Siobhan mentioned, we're working on a hybrid option to allow for in-person or virtual attendance. So we'll have more information on that and other options probably by the next board meeting. And with that, that's all I've got today, Siobhan.
All right, thank you, Ollie. So it looks like after this, we have an innovation work group update, and I believe Margaret is going to be presenting.
Yeah, good morning. Thank you, Chair Martin and members of the board. I will actually not be presenting. I will just be giving a really quick introduction and then handing the presentation over to Willis Towers Watson. But just to sort of provide the overview related to this report, as you'll recall, under Senate Bill 1067, which passed in the 2017 legislative session, payments to that carriers make to hospitals, but for both inpatient and outpatient services for OEB and PEB members are capped at 200% of Medicare for in-network facilities and 185% of Medicare for out-of-network. And this relates specifically to 24 hospitals in the state of Oregon that meet criteria under the bill. The statute includes some specifics that excludes certain types of hospitals, generally the smaller ones. This cap generally applies to the DRG facilities. And so the cap, if you'll recall, took effect in October 1st of 2019 for OEB and January 1st of 2020 for PEB, with the start of each benefit plan year, respectively, for the PEB and OEB groups. And so the report you're going to hear is an audit report related to the first year of application of the hospital cap. So specifically, this is calendar year 2020 for PEB. And for OEB, it's October of 2019 through September of 2020, September 30th of 2020. And Willis Towers Watson undertook the analytical work to perform this audit. And so I'm going to hand this over to Brad Lawson from WTW to walk the board members through the report and take any questions. And Brad, you can indicate, your preference if you'd like to take questions as you go, or if you want to try to hold those till the end, just share your preference on that.
Yeah, absolutely. Thank you for having us here and allowing us the opportunity to present this information. I always love a good dialogue. I have to confess I'm having a little bit of PC issues right now, so I can't actually see the screen presented, but I have my own copy of the presentation up. So always a lot of fun, doing these virtual meetings. Be fun to get back to the live stuff in a while here as we settle down with COVID. But yeah, as we go through this, please, I'll watch for hands as I can, but definitely just speak right up. This is a summary of the full report that was presented to the IWG group in late December. And, as Margaret mentioned, there's a number of background items on here, lots of complexities in here. But as we look at, I'm on what I can see as page 3, which is the executive summary. If someone wants to give me a great indication, if everybody can see that right now. Okay, thanks, Margaret. I'm going to watch for your nods.
Okay, yes, we can see it. Thanks, Brad.
Okay, perfect. As we move on, and so in general, we can see that as we look through the results here, Moda, Providence, and Kaiser did all separately meet the criteria of SB 1067. As Margaret mentioned, the bill does limit facility reimbursements to 200% of Medicare for in-network and 185% for out-of-network. And while it does apply at a claim level, compliance is determined at a hospital level. So those will be two important and interesting things to remember as we walk through these summary of results. In general, reimbursements at the hospital level are in compliance, although we did have a few hospitals that showed some modest level of overpayment. Nothing alarming. When we look at it on an individual claim level, there does appear to be some opportunity for further review with the carriers. And so that's kind of our overall result. Good news. We look like we're in compliance in general with good results. However, as a supplement to the audit analysis, we were also asked to review the savings from 1067 to see how it compared to our initial estimates of, I believe, 81 million or 23% of facility claims that were subject to 1067. So actual savings here were 59 million or 14% of those subject claims. And that variance was driven by three key things. One, in particular, the delayed implementation of clarified rules. We did a little bit of looking at preliminary 2021 data, and that is indicating that we will see lower average reimbursements compared to 2020, which will drive, of course, higher savings levels. And then we also had significant change in utilization due to the pandemic, And then frankly, we kind of think that our estimated savings may have been a little bit too high as we went through and really did a detailed claim by claim analysis. We did end up with a lower percentage of Medicare pre 1067 than we were thinking before implementation. So any questions before we dive into details? Okay, so we can move on to what is my slide 5, the audit results. And it starts with total allowed claims. Are we there, Margaret? Okay, perfect. So this slide shows the amount of facility claims that were impacted by 1067. And we can see of the 200 plus hospitals with incurred charges, there were approximately 620 million in allowed claims. 13% of these were outside of Oregon and 22% were in Oregon, but at exempt or non-subject hospitals. This leaves about 65% of those claims, or a little over 400 million, that were incurred at subject facilities. You know, for these results are very similar for OEB and PEBB, and also by carrier, with MOTA and Providence having similar percentages, a little bit lower, and Kaiser having a little bit larger percentage of those claims subject to 1067. And of course, if there's a lot more detail that's in the full audit report, if anyone is interested in obtaining a copy of that and diving further into those details. Any questions on this slide before we move on? Okay, we can move on to the next slide, which is kind of the meat of the presentation. You know, there's lots of numbers on this slide, so it's worth taking a quick overview or a quick orientation. You know, of course, we have our combined results and we separate them for OEB and PEBB as we go across the columns. And we're going to start with the subject claims that were subject to 1067. You'll note they're a little bit lower. There were some claims we were not able to match, but in general, we captured nearly all of the 400 million that were subject to that. We have the resulting reimbursement as a percent of Medicare, and then a little bit more detail on overpayments by inpatient, outpatient at the hospital and the admission level. So, you know, in general, overall, we see claims are reimbursed at 179% of Medicare, which is below the 200% Medicare cap. When we aggregate those at a hospital level, as we mentioned, only a few facilities had a modest overpayment of about 700,000. If you're looking at that combined column, that's your inpatient of 500,000 and outpatient of about 200,000, the 0.5 and 0.2. However, when we look at the results on an individual claim level, which means that overpayments are not offset by underpayments, both OEB and PEBB had approximately 2% of claims paid over the 2%, 200% cap. There does not appear to be a significant difference in these results between OEB and PEBB when we're looking either at inpatient or outpatient, or at a hospital or at an admission level.
I just had a question around the overpayment at the individual level. Was that rectified through the audit process, and were people refunded?
You know, that is kind of on our next steps. So we'll get into that a little bit more.
Okay, thanks.
Good question. So the short answer to that is, I think the next steps are really to, you know, this is an estimation process. The next steps would really be to work in a detailed way with the carriers to provide them with a listing of those claims and have them, you know, justify the payment process. And sometimes there's a difference of interpretation. Sometimes there can be a difference of additional DRG detail that either we had or they had that drives different reimbursements. But I think, you know, at an immediate next step, I think is just working on reconciliation with the carriers on those detailed claims. So not necessarily saying they were right or wrong, just looking from our perspective, they do appear to be some level of overpayments. You know, when looking at a hospital level, which is where our compliance is at, you know, there were some underpayments as well. And so when we look at those in aggregate, you know, we're fairly close to the mark. Good question. Thank you. Okay, any other questions? Okay, I think we can move to the next slide, which is our savings analysis. Margaret, are we there?
Yes, we are. Slide 8, correct?
Yep. Perfect. Okay. So while there's only 3 lines on here, there's a lot of numbers and a lot of things, to review. Again, worth an orientation. We thought we'd show a multi-year look to see what savings could have looked like in a non-COVID year, as well as the year of, the 1067 implementation. And so as you look on here, you'll see 2 primary sections. We have one section that is 2019 utilization, and that sort of represents our pre-COVID period. And then we have our 2020 utilization, which represents experience during our COVID or pandemic year. And that's the year we're actually measuring results subject to 1067. Each of those sections, we're going to have total allowed costs. We're going to have percent of Medicare before 1067 and a percent of Medicare after 1067. It's worth pointing out that in all cases, the percentage of Medicare before 1067 is based on 2019 contracted rates or pre-1067 contracted rates, and the percent of Medicare after 1067 is based on 2020 contracted rates, or 1067 subject results. So we're going to have a percent of Medicare before and after 1067. We'll have sort of actual or estimated savings under 1067, sort of how did we do or how could we have done in the case of the 2019 utilization, and estimated savings if the clarified rules had been enacted. And recall the clarified rules said, hey, you really were going to lay it out real clear that you have to charge either the lesser of billed charges, contracted rates, or our 200% of Medicare cap. And that was implemented, I believe, in late 2020. All right. So we're going to have those savings, and we repeat those for the 2020 utilization. So in general, we see for inpatient that our pre-1067 Medicare percentage was 182%, which was already less than the 200% of Medicare cap. After 1067, we really had very little or no change in there. It remained at 182%, and that of course drove very minimal actual savings based on this 2019 utilization. However, if the clarified rules had been in place and we would have re-adjudicated those, it's estimated that savings would have been nearly $27 million. So kind of looking ahead, hoping and thinking that those clarified rules should have a significant impact. For 2020, kind of our utilization mix drove actually negative savings compared to 2019. So we started at 176% is where we would have been based on our 2020 utilization. We ended at about 180%, and we actually had a cost increase of about $4.5 million in total. However, if the clarified rules had been in place, we estimate savings would have been about $13 million. For outpatient, our pre-1067 percentage of Medicare was much closer to estimated, between 240 and 250%. And then for 2020, kind of skipping ahead, our earned savings of 64 million, 63.8, actually exceeded what we would have expected given the 2020 case mix. All right.
So just I just wanted to clarify. So I'll speak for myself. I know it was a frustrating process that we had to clarify the 200% cap. We discussed that multiple times as a board, and we thought the law was clear. Yes. And are we, I know you're going through these step by step. What I'm curious to know is, because we did see some creep in terms of some of the costs going up, and we see this with MODA on here, we see this with Kaiser on here. Will those numbers then go back down with the clarified rules as we move forward?
In theory, yes. So, and what's happening, I think that the pregnancy and neonate is a great example, skipping way ahead, of course, in the presentation. That's a really good example of that, under a Medicare pricing structure, that probably doesn't come into play very often in the Medicare world, right? Maternity costs and those kind of things. And so probably not a lot of focus or analysis given as to those at the federal level. Whereas with this population, of course, we have lots of maternity and things like that. So we did see those costs coming in at much higher than they were on an allowed basis. So we were starting at a very low percentage of Medicare on a commercial basis, or pre-1067, and then those facilities really ratcheting those up quite a lot to take advantage of the 200% Medicare cap and their interpretation that they could do that. So if contracted rates and billed charges stay the same, yes, we can expect those costs to come down and drive additional savings. I think we're going to have to be very careful from a contracting and a due diligence perspective to watch for changes in the charge masters of the facilities that could up those billed charges, and changes in the contracting from the carriers that would allow creep of the allowed costs closer to those billed charges. And I think those facilities will be putting a lot of pressure on that contracting process to the carriers. So does that answer your question?
Yes, thank you.
Mm-hmm. Absolutely. All right.
So
mm-hmm.
this is Sean, just to add on to Siobhan's point for the new board members, we're not really belaboring it at this point because the board has made itself clear multiple times, but just for the sake of historical context, I think the board has made itself pretty clear in various formats that we felt that the law originally was pretty clear that obviously you would build the lesser of. The point of the law was not to raise prices up to 200% of Medicare. That was obviously not the point. Feel like that was obvious, but for whatever reason, others didn't think that that was obvious, and so we had to make rules to be explicit about it. I feel like that was a failure of due diligence on the part of the carriers, and they didn't advocate for us. But hence this cost difference here. So, pretty disappointed in that performance on our behalf. They weren't really looking out for us clearly. So the law was clear, but regardless, we added some additional rules in order to make it even more clear it's the lesser of expectation. So that's the context, and we're just kind of not beating it to the dead horse at this point because we've already done that in several formats. But that's kind of what's happening behind the scenes here.
All right, thanks. That's a great context. We can finish up with just a couple highlights on a carrier basis. When looking at inpatient, we did see the MOTA percentage of Medicare increase from 170 to 188, which had a modest cost or a bit of a cost increase. We saw the Providence percent of Medicare decrease from 199 down to 187 for a cost savings. And then Kaiser percent of Medicare increased from 146 to 154, which also resulted in a modest cost increase. And in total, then we see savings of about 59 million, as we mentioned, 14% of subject claims, with inpatient driving actually a cost increase in 2020, and outpatient driving cost savings of about 64 million, or about 27.3 million. All right, so we can go to the next slide. All right, so we thought we'd highlight just a few, and we're on slide 9, Margaret. Everybody seeing that? Okay. So we thought we'd highlight a few of the top inpatient DRGs that drove both the increases and decreases in cost. So on the left-hand side, we've got kind of a description as well as a code, if any of you are really familiar with those codes, as well as 2019 and 2020 utilization. We thought it was interesting to go through and see if there was a large increase in some of these service categories that had a significant increase in our claim allowance. We have the total 2020 allowed cost to give context from a magnitude perspective, and then we have our percent of Medicare before 1067 and our percent of Medicare after 1067, as well as the actual earned savings and earned savings percentages noting that of course negatives are actually cost increases in this context. So we've supplied the top 6 cost increase drivers. There's 6 of those that have negative savings, as well as the top 6 savings drivers. And a couple interesting observations. While the cost increases, those negatives were generally concentrated in just a few key DRGs. The cost increases were spread much more evenly across many more DRGs, which is why you see the earned savings differences can be pretty substantial there. The cost increases were concentrated in neonate DRGs, notably 789 through 794, although we did see some of those neonate DRGs having a cost increase, such as 787 and 788, which are shown on there as well.
And Brad, as you mentioned on the last slide, this is where we should see more savings because we should expect all those neonatal costs that went up to go back to 2019.
Correct. Yep. And I think, if you just look at some of the big numbers that pop out 4 down, 793 and 794, those were driving well over half of your cost increase just in those 2 cost categories. And you can see that we went from 62% of Medicare all the way up to 157% of Medicare. So we had very substantial increases in cost for those services. In theory, that starting 62% represents a contracted rate that was in place back in 2019. And assuming that contracting stays consistent and the billed charges don't go way up, we would expect the cost to come down by those levels. So again, that's really where, to Sean's point, really due diligence in support of that carrier contracting and significant involvement there to make sure that those we don't see the cost increase in the contracting.
Thank you.
Mm-hmm. All right, any questions on this savings by DRG? If not, we can move on to the next slide. I'll just comment on we don't have any outpatient. We did have a little bit in the full deck, but outpatient in general performed as expected. So we didn't see, that started much higher as a percent of Medicare, and we didn't see that kind of aberrations that we saw on the inpatient side. So as a final look here, we did take a look at the percent of Medicare relative to our commercial benchmark. That was based on IBM Watson's database of 2019 market scan data, which was the most recent available at the time. And you'll note that, before 1067, we had both OEB and PEB inpatient costs were below the benchmark, averaging at about 176% versus 200% for benchmark. While on the outpatient side, our costs were above benchmark, averaging at about 243% versus 196% for benchmark. And then after 1067, both OEB and PEB costs for both inpatient and outpatient were approximately 180%, which is lower than the benchmark, which is close to 200%. So kind of in the table up above just has a lot more detail on there with some magnitude dollars as well, so you can see what the kind of resulting impacts might be. So in general, successful, bringing it lower than benchmark, which is great. Interestingly, inpatient costs already below benchmark at the time. All right. Any questions on that slide before we move on to our kind of our summary and next steps? All right. So we're on slide 12 in the presentation. I'm not sure what number it is on the PDF, but in general, most hospitals appear to be meeting the criteria per 1067. However, we noticed there are some modest overpayments, not a whole lot though. When looking on a per admission level, there does appear to be some overpayments, and we think the next step would be to work with the carriers to reconcile and resolve those payments. So a little bit of opportunity there. And while total savings were less than expected, this was driven primarily by inpatient. We think that the implementation of those clarified rules in late 2020 should help to alleviate that or rectify that. So from a next steps perspective, working with those carriers to resolve potential per admission overpayments. And then I think determining the frequency of future audits. We at Willis Towers Watson, we're thinking maybe every 3 years, although potentially conducting an additional savings analysis once the 2020 full 2021 data is available, which would be, frankly, I think around next month. That should be available in the data warehouse for both OEB and PEBB to sort of validate and monitor how the clarified rules are impacting that and monitor the changes in contracting over each year.
I do think, I was just going to make the comment that doing an audit soon makes a lot of sense given the high numbers that we saw around the neonatal care in particular, or the overall natal care.
Yeah, I agree. I think our experience, for me, has confirmed that we have to watch this implementation like a hawk. Like trust is low, let's say. So, we're going to need to watch it super carefully and bring it up when we have questions.
Absolutely.
So any other comments or questions on this topic? All right, well, thank you, Brad. Thank you, Margaret.
Absolutely.
Thank you.
I believe we are moving to our next piece, which is April Kelly is going to talk to us about filing a permanent rule with the Secretary of State. And so, yes, thank you for flipping forward, Rose.
Hello, can everybody hear me okay?
Yes.
Perfect. And I apologize, my animals are going nuts this morning. So if my cats start swinging from the curtains behind me, just ignore them. It's the joys of working from home. I'm going to talk about attachment 3, which Rose has on your screen, at least it's on my screen, which is page 26 in your packet. And if you were at the December 21st PEBB board meeting, I did go over these rules. I was asking at the time to file one in particular temporary and then take them through the rulemaking process. And so that has been done. I am back asking I have a recommendation, but before we get to that, I just wanted to kind of bring you guys up to speed. A lot of what you'll see in these rules in these next 4 pages, if you've had a chance to read through them, the bold and underline are adding, and then the strike through is deleting. So back in December of 2019 and kind of the fall, we started looking at all of our rules, as we do periodically, because as processes change, we need to update our rules to keep up with our process changes. And so a lot of what you'll see in here in my attachment 3 are housekeeping or really clarifying PEBB's processes. But the one change that is the reason that we started with our Division 15 rules is because of Senate Bill 748, which expanded the definition of disabled dependent or dependent eligibility for PEBB coverage.
April, I believe you went on mute.
Oh, that is, sorry about that. I shouldn't hover over the mute button, right? But what I was just saying was that at your December 21st board meeting, you did approve staff to file Division 15 in Section 11 is what we filed as temporary to get that into effect to align with the effective date of Senate Bill 748. But that's all I have. So our recommendation, this did go through the public rulemaking process. We did hold a public hearing, and we didn't get any comments. We did take this back through staff just to verify that this is the language that we're comfortable with, and so now I'm bringing it forward today and asking your approval to file these with the Secretary of State's office as permanent rules.
So thank you, April. And yes, we did discuss this at the December board meeting. And so I will entertain a motion around moving this forward.
So this is Kimberly. And I'd like to make a motion that we file to permanently adopt OAR 100-015-005 and 0011 and 0026 and 0045.
All right,
With the
thank you,
Secretary of
Kimberly.
State.
And do I have a second?
This is Greg. I'll second.
Great, thank you, Greg. So I have Kimberly as our first, Greg as our second. Andrea?
Approve.
Dawn? I noticed Dawn said be right back, so she may not be with us at the moment. Kate?
Yes, I approve, or vote to approve, or the right thing, sorry.
Sean?
Approve.
Jeremy?
Yes.
And let me check one last time. Dawn, are you here? Are you back? All right, well, we have quorum without Dawn, so the motion passes. All right.
Great.
Thank you,
Thank
April.
you so much.
So we actually are a little bit ahead of schedule. So we're going to have a 14-minute break instead of a 10-minute break. So we will come back at 10:30. All right. Thanks, everybody. See you at 10:30. All right, welcome back from break, everyone. So we have Andrew and Emery who are going to be presenting for us on the round 2 renewals. So Andrew, should I hand it off to you?
That would be great. Thank you.
All right, thank you.
Sorry for the slides to queue up. So hello, everyone. Nice to be with you today. Today we're going to be walking through round 2 of 3 as it relates to renewal responses. And so myself and Emery, Mercer lead actuary, are going to sort of be going back and forth as we go through this content. Normally Mitch would be here with us. He's out today, and so I'm going to do my best to sort of carry the torch as it relates to some of the more detailed renewal slides. You know, as per usual, definitely jump in with questions. You know, we welcome discussion as we're going through. If you want to hold until the end, that's fine too. Whatever is your preference works with us. So, okay, I see we're on the agenda. Thank you, Rose. And so a big part of the discussion today will be follow-up items based on our conversation that we had last month as it relates to round 1 of the renewal review. Included in that will be some utilization follow-ups that exhibits and analyses we put together based on some questions that were posed a month ago. We've got an update for you on the composite rate with some additional months of data. We also have a financial roll-up that's going to look at your aggregate annual costs on a projected basis. And so a lot of good stuff. And like I said, please do jump in if you have questions throughout. We want to jump to the next slide, please. And so we do have, as per the past few board meetings, we are including the guiding principles and then the health equity pillars on the next slide. And this is a great time of year to do a revisit on both of these slides, simply because both of these are sort of frameworks through which we can look at a given renewal decision and sort of evaluate it and say, does it still fit within the strategy of the guiding principles, or is it advancing our health equity goals, that sort of thing. And so, you know, I'm sure everyone is familiar with this slide, but it is based on the foundation of the triple aim. So improving quality, improving the patient experience, and then delivering care more efficiently, and so cost reductions. And so the way that this is set up is, you know, the state of Oregon, via the governor's office, has their own priorities as it relates to these 3 goals within healthcare. OHA has their own guiding principles as well. And then we've got the PEBB vision, which has a little bit more detail there towards the bottom of the exhibit here. And so, you know, with all of these principles and, you know, sort of guiding strategy, there's 3 primary stakeholders that PEBB is focused on: the members, of course, first and foremost, healthcare delivery system, and then the needs of the board itself. And so, you know, just picking out a couple of things from the PEBB vision, focusing on an innovative delivery system, focusing on evidence-based medicine, improving quality and outcomes, and of course, a huge focus on health equity, which if we want to flip to the next slide, Rose, we can take a look at that in a little bit more detail as well. And so these health equity strategic pillars, like the guiding principles, can be used as sort of a framework or a lens through which we can evaluate all the decisions that the board will need to make for 2023. And so this was a result of one of the retreats from 2020. And it's useful for lots of reasons. And it's not the only result that came out of that board retreat. In other words, the subcommittee on health equity. And so in speaking with Michael and our team, who's a part of that health equity operational subcommittee team, they did create some criteria for determining when and how we'll use the health equity screening tool when we're evaluating renewal decisions. And so the direction from that subcommittee is to look at any plan changes that could negatively or adversely impact members. In those instances, let's put it through the health equity screening tool and see what the results are. And so for certain benefits where we're really enhancing the member experience or enhancing the benefit, whether that's allowing for additional types of coverage of healthcare services or increasing the limits for different benefits, lowering cost share, these are instances where we're actually excluding those types of renewal changes from the health equity screening tool because they are sort of increasing access and reducing cost in a more broad way where certain populations are likely not adversely impacted. And so when we get together a month from now for round 3, we'll review best and final offers from the carriers. We'll also take a look at the health equity screening results for the DPP solution, as well as breast reduction surgery. And so we do have an update on those items in here, but we'll really sort of get into a lot of this sort of health equity results in more detail next month. Okay, Rose, if we could flip to the next slide, please. This is just a recap of a decision that the board made from last month. And so this was around coordination of benefits. And so aligning all the plans to ensure that there's parity in terms of how these benefits are offered. For instances, when a PEB member has their own PEB coverage as well as their partner's PEB coverage, and ensuring that they have access to the limited and capped benefits under both their plan and their partner's plan. So for example, things like acupuncture, which has a visit limit attached to it, an annual visit limit, or things like fertility, which have an annual cost cap. The board voted to allow members to tap into that benefit through their own plan and through their partner's plan. And so now all 3 health carriers are aligned in terms of how those benefits are administered. Any questions so far? All righty. With that, I will hand it over to my colleague Emery, and we can revisit an updated composite rate calculation.
Thanks, Andrew. So on this slide, we are showing the composite rates for PEB. These are historical, so it starts in 2014 there at the top, and it goes down through our preliminary projections for 2023. On the left-hand side, these are using the March census, so it would be basically the premium rates times the census as of March, and I guess for 2023 it would be March 2022. The amounts there are the PEB funding amounts that would essentially be subject to the 3.4% limitation that's imposed upon PEB. Down at the very bottom, we do have the preliminary. This will be updated again next month once we actually do get the March census in. Unfortunately, the timing just is not possible as we received the March census basically, I think, pretty much today. So this is based on the January census. But if you remember from last month's meeting, the composite rate was actually a little bit higher as we updated with additional self-insured claims. The composite rate actually dropped. So our projected cost before was about 3.5% change. Now it's a 2.7% change. So 2.7 is less than 3.4. And so right now you are below the limitation by about $7 million. So there are, right, as it currently stands, no required plan changes to get under that limitation. So,
Emery,
yes.
a quick question. So we have updates from the self-insured, but not yet from Kaiser. Is that right?
That is correct. Kaiser has not provided updated premium rates. So those numbers, which actually will be on the next slide, are unchanged from the prior month. So right now, I guess this is pretty good news. A little bit better experience. January claims were a little bit lower, and the 2020 claims were a little bit lower. And so overall, the costs, projected claim costs for 23 did come down a little bit. And any other questions before we move on to the next slide? No? Okay. So next slide shows each of the different plans, as well as the lines of coverage that they cover, the admin fee increase, and the premium. And that says final, but it's not actually really final. We'll still take another look at it with potential plan design changes and other potentially updated claims, as well as the impact on the composite rate that each plan has. So starting from the top row, the statewide plan, the admin fee increase is 3.2%. Our pre-stated self-insured cost is 1.3% increase, so well below the 3.4%. And so it has a relatively small impact on the overall composite increase, 0.3% of the 2.7 total. The Providence Choice Plan, the restated cost increase is 5.7. So that is lower than what we showed last month, but it is still the highest cost increase for all of the plans, and it makes up almost half of the composite cost increase in this case. Kaiser is shown below. 4.9% is a preliminary premium rate change, and that's about 0.7%. Again, that's unchanged from last month. MODA, the cost did decrease a little bit as well. So the projected increase for 23 is 5%. And so they represent about 0.5, or about 1/5 of the overall composite increase. The next couple elements, MODA Dental, Delta Dental of Oregon, actually has a projected rate decrease, 1.5%. So it does reduce the overall composite rate. And then Willamette Dental Group, they provided a rate concession of 2.5%. So that helps as well. Kaiser Dental, again, the preliminary premium rate unchanged from last month, 3.4%. And then VSP, we're projecting a decrease of about 4% for VSP. And so a little bit of savings there. So overall, about 2.7% composite rate increase, essentially made up of medical cost increases, but a little bit better news on the medical compared to last month.
I can see that Ali has his hand raised.
Yes, Ali?
Thanks. Just a quick question. So Emery, is it safe to say that some of our higher risk members are moving from statewide to choice?
Actually, I think MODA actually had I'll actually have to take a closer look at it. I know there's definitely switching to the coordinated care model plan. So I believe MODA actually had a pretty good size increase for 22 compared to last year. So that does provide some savings in terms of the overall composite rate. In terms of the high risk members, I've actually not taken a close look at that in terms of how the risk of the members are switching. That's something we can definitely do to take a look at. I know we've done it in the past.
Thank you.
Okay. All right. Any other questions? Nope. Okay. With that, I guess we'll move on to round 2 responses and follow-ups with Andrew.
Right. Thank you, Emery. Okay. So, all right. This first slide of guide. Oh, sure. Yeah.
Sorry, this is Dawn. I didn't get to put my hand up before I wanted to jump in. I have a question about the equity, the application of the equity lens, and it goes back a couple of slides, so it might not be you, Emery, it might be Andrew. And the question is, I heard that we are selecting to apply the health equity impact analysis when when a benefit is going to be decreased to be to assess for the impact. Did I understand that correctly?
So you did. I would say that there is a little bit of nuance and gray area there. For example, we've looked at the diabetes prevention program as well as the medically necessary breast reduction surgery changes. We've put both of those through the health equity screening tool. Those aren't takeaways per se, but there were sort of other reasons to put those through the tool. So when it comes to DPP, you know, one of the requests we made, we had our required criteria and then we had our other preferred criteria. The preferred criteria largely related to health equity. And so that's probably a long answer, Don, but there is sort of a little bit of judgment that goes into it as well.
Okay, I thank you for explaining that. The question that came up for me is the flip of it, which is if we are expanding benefits, are we assessing how those expansions of benefits impact equity? That is to say, which populations do we anticipate benefiting most, and or are we using that kind of analysis to help drive which benefits we might expand or deepen? That is to say, to identify which populations uh, uh, may need something that they're not currently getting. So are we using an equity impact analysis in that way in our determination about benefits?
So we are, yeah, absolutely. Yeah, and I probably wasn't clear in the way that I described it, but if we look at, again, like DPP, for example, there are specific preferred criteria that sort of targets specific populations, which are priority populations for the board. And so accessibility for members with disabilities, for example. And so there are instances where we'll use the tool to determine if a given enhancement or additional access is sort of being rolled out in an equitable way to try to advance those goals as it relates to the priority populations and other groups.
That's great. Thank you for that clarity. I may have missed it in the prior work. Thank you.
Oh, sure. You know, you're good. I think I could have given a little more detail. So thank you. That's great. Great question. Okay. And so I think we're on, let's see here, slide 9. This is another follow-up from last month. There were some questions around justification or rationale for the administrative fee increases that have been proposed by Providence and MODA on the medical side. And so what we've got here, we've got the ASO fees, historical, so last year, current 2022 fees, and proposed 2023 fees. So you can see what's being proposed in terms of an increase for 23. And we've broken it out by the two Providence plans by MODA, and then the MODA 360 fixed fees as well, which is the component of the fee that's being proposed to increase on the MODA side. And so we posed this question to the carriers, and we've got a summary of their response on the right. Apologies for the small text. In hindsight, we probably could have summarized it in a slightly higher level way, but Providence responded and called out some of the components that are included in their administrative fee. And so wellness programs, digital point solutions, some of the other stuff that's included in what you guys are paying today. And then in terms of the increase for 2023, they called out that wages in Oregon are expected to grow by 4% after 2022. And they also called out the fact that 60% of the revenue that they get from the ASO fee directly goes to cover Providence wages. And so another reason that they called out, in addition to the expected wage increases, is around inflation. MODA had a similar response as it relates to inflation being one of the drivers for the proposed fee increase. They also called out a couple of enhancements that they're rolling out system-wide. And so things like chat and push notifications have been rolled out. A member dashboard will be rolled out in 2023. And so with these types of investments that they're making to sort of enhance the member experience, there's a cost associated with that. And so to cover that cost, they're proposing the increase to the MODA 360 fixed fees. You can see it's $497 currently, and they're proposing $512 per employee per month in 2023, which is a 3% lift. Another comment I'll make here, if you're,
it
sure.
looks like Sean has a question.
Oh, thank you. Yes, Sean.
Not necessarily now, but one of the questions that I'm interested in, that we often end up getting kind of wrapped around is, part of the expectation in costs for managing care is programs to help people have their best health, tobacco cessation, diabetes prevention, so on. Theoretically, that those programs end up having a cost savings over time on the backside, on the medical costs, see, because you're preventing cancer, you're preventing amputations for diabetes and so on. And there's this kind of line of like, where are those expenses? Like, some of those benefits are baked into the actual plans, and then some of them are kind of in the administrative costs, sort of. And then it's kind of like, where are we counting it? And are we double counting it in order to justify fee increases, that sort of thing? So it's complicated, but that is something that I'm interested in hearing you tell us more about. Not, as I say, not necessarily right now, but when we're really talking about fee, like, does it make sense that whatever the thing is, does it make sense that that's in the administrative cost? Is that actually in fact in the medical costs, or should it be as kind of like a core benefit or whatever? So if the cost increases are going up for that program, let's say, does it make sense that the administrative costs are going up, or should that be reflected somewhere else? So just having our pieces, that sort of thing. So